issues in management follow-up. Let us start with a case. A 28 female, 35 weeks pregnant, with a dyspnea history for 1 month, which was not diagnosed, was labeled as baby of third trimester, breathlessness. She presented to us with ECG of sinus tachycardia, echo shows was LV dilated, 58/40, global hypokinesia, EF of 30, moderate MR, RVSP 60. After ruling out other causes of valvular heart disease, pre-eclampsia, we diagnosed her case of pericardial myopathy. Now the question comes to us, these are the points in which my talk will be basically specified, how to manage these patients, which drug to be avoided during pregnancy and postpartum, what should be the plan of delivery and mode of delivery and timing, should we advise breastfeeding in these cases, what should be the mode of contraception for the next pregnancy, and should we advise further pregnancy in these cases or not? Because these are the challenges which we see daily OPD when these patients come to us and we really don't know what to do about it. So, about the little theory part, we all know peripartum cardiomyopathy, if we see the definition, usually happens during the last month of a pregnancy or during the postpartum period, and it is ejection fraction less than 45%, and you have to rule out, it's a diagnosis of exclusion, and incidence varies upon the geographical status. And if we see, this is not related to your hemodynamic stress during pregnancy, because if we see the maximum volume overload happens during second trimester, whereas the peripartum happens during the late trimester, end of pregnancy or the postpartum period. So it is basically a vascular disease which is triggered by hormonal changes during pregnancy, especially during delivery and the lactation time period. So if you see the pathophysiology, they have various dimensions. They have prolactin. Why am I talking about prolactin? Because the treatment strategy now being analyzed to target this prolactin levels. And then there is angiogenic imbalance, inflammation, myocarditis, and genetic mutations, which lead to your vascular dysfunction, injury, and leading to your decreased myocardial function. And if we see along with this, why it is like this hormonal changes happens in every pregnancy. So why only particular women are involved? So now comes the role of the genetic, because they have been shown the various genetic parameters of TTN and SFLP. They have shown to that they will increase risk for developing pericardiomyopathy. What are the risk factors in these patients? We say that there are multiple hit theory. You have environmental risk factors, you have genetic risk factors. Malnutrition has been said because they have said that they are more found in the patients who are in low socioeconomic status, and especially those who have malnutrition. Along with ethnicity comes an important role with genetic factors, elderly patients, multiple pregnancy, diabetic, hypertensive, they all have been associated with your increased risk. So coming back to my case, what management should I give this to pregnancy? We all know HFrEF, there are 4 pillars of heart failure. Should I use all the 4 pillars of heart failure in these patients? Beta blockers, yes, but we have to be careful. We have to use a lipophilic beta blocker. Most commonly and most safe has been studied is metoprolol. Avoid atenolol. Atenolol is considered to be crossing the placenta, and it causes fetal bradycardia and decreased growth reduction of the fetus, so it should be avoided. ACE, ARB, ARNI, they are completely contraindicated in pregnancy. Aldosterone antagonists should not be used. It's contraindicated because of anti-androgenic effects. SGLT should be not to be given during pregnancy. There is no data. And loop directors to be given in these cases. So we are left with only 2 pillars in when they are pregnant, either a beta blocker or a loop diuretic in these cases. If the patient, some stage digoxin has considered to be safe, and along with the patient have a systolic BP more than 110, hydrazine and nitrates should be given in these patients who are not being controlled by beta blocker or loop diuretic. So coming to back my case, her NT-proBNP was 8,000. We started on furosemide oral, 20 milligram, metoprolol 25 milligram OD, but patient symptoms worsened. She didn't improve. She came back within 1 week of our treatment, 36 for pregnancy. She was in NYHA class 4, orthopnea, PND, chest were full of crepes. We admitted her in ICU. We started with her NT-proBNP has risen to 15,000. We started with IV loop diuretic, started digoxin, and her BP was on the borderline of 90 and 100, so we were not able to give hydralazine and isonitrate in these cases. She got little stabilized. She's already 36 weeks of pregnancy. Now, what should be the timing of delivery? Should we ask her, consult the gynecologist, okay, you need to deliver this baby or you have to wait. Now, mode and timing of delivery depends on the hemodynamic stability of the patient. If the patient is hemodynamically stable with medical therapy, we can wait till 38 weeks. But if it is unstable and going into recurrent pulmonary edema, then it is better to do an early delivery. What should be the mode of delivery? Stable patients all should be advised of vaginal delivery in these cases unless there is an obstetric reason for the cesarean. And cesarean should be done in only who are hemodynamic unstable, who need to be intubated in these cases. Then cesarean is preferred in these cases, have to be done. The biggest challenge comes during the third phase of your delivery, when the stage of delivery, when there is a increased volume overload, uterine contraction, fluid mobilization. Then you have to be very careful, watch, and the third stage of labor should be shortened in these cases, and postpartum risk of fluid overload and pulmonary must be anticipated, and a cardiologist and a good cardiac anesthetist should be present whenever we're going for the delivery in these cases. So in our case, patient didn't stabilize. At 37 weeks, we said, okay, we need to deliver this because this is the maximum right time at this, because we are able to get a good pulmonary got solved. So went under normal vaginal delivery, close monitoring of volume status. But again, on second postpartum day, she again developed NYHA class 4. She was in pulmonary edema. Again, now what to do now in these cases? So we again started IV diuretic and infusion. Other supportive measurements were started. Now she is post-delivery. Can anything else be added in these cases? So the drugs which were 4-pillar therapy, which we stopped during the pregnancy time, so we come to postpartum or lactation. We continued with beta blocker, and now ACE inhibitor can be added in these cases. We started with captopril, enalapril, and benzaprid are going to be safe. ARBs are still contraindicated whenever these are postpartum period, and aldosterone antagonists now can be given. SGLT2, no data at present, so it's usually contraindicated, and loop diuretic to be continued. So we started her on metoprolol 25, we added spironolactone, we added ACE inhibitor in her case, and fortunately patient have some improvement, but still she was in NYHA class 3. So is there any other drug which can be added in this case, because she is a very high-risk patient of EF of 30%? Come over the class of bromocriptine. Now, bromocriptine, as I already told, why I was talking about prolactin, the prolactin is considered to be one of the risk factors for developing your peripartum cardiomyopathy. So it's a dopamine agonist, inhibits the release of prolactin, and it has mechanism have been shown that it is indicated in moderate and severe heart failure patients. The dosing, still not very clear. Several studies have used different dosing, but usually it is a 2.5 milligram OD for 6 weeks, or some have done a little higher dose of 2.5 milligram BD for 2 weeks, followed by OD in 6 weeks. But the biggest challenge, you have to give prophylactic anticoagulation. This drug is not which is being recently, it is there for long, but why it is such a debate is going on? Because there are certain pros and cons in these cases. The biggest cons is the thrombotic complication, and we are unable to breastfeed these patients. So we still need a strong data to tell, okay, bromocriptine can be given and not. So there's the recent data, which was about 2025, published in March. This was basically a registry which they showed that the patient of European registry, which is a big peripartum cardiomyopathy registry, they took 552 patients of peripartum cardiomyopathy, out of which 84 were treated with bromocriptine. That was 15%, and the endpoint which they took was a maternal outcome, that is your death, hospitalization, and 6 months at the end of the 6 months. And at 6 months, they used the LV ejection fraction. To their surprise, they found, despite these patients who were more sicker, they were in NYHA class 4, the LV ejection fraction was much lower, they did better when these patients in a primary outcome is a p-value of a just static. Actually, it's not coming very clear. It was 0.044 when these patients, when they were giving bromocriptine in these cases. And the majority of these patients belong to African areas and a lower socioeconomic status of these patients, and despite that, they had a better outcome. So, and they didn't find any difference in thromboembolic events, because this is the data of registry. They didn't find, because which is a risk which they have mentioned of thromboembolic, they didn't find any difference. But data is still awaited. A rebirth study, which is a randomized control trial, which is being done in US in multiple centers, and they are trying to compare with whether it's data that whether the bromocriptine will really help or not. But till 2029, we are still in a dark, so whether to give these patients bromocriptine or not. So what does the guideline recommends? Recently published ESC 2025, last month, they still give a class 2B because we still don't have a randomized control data. So they say only in the patients who have an advanced heart failure, who do not have a good recovery in these cases. What about the anticoagulant? Should be given in all cases. There is no clear-cut recommendation. Some few case series are there who say, okay, there's an ejection fraction less than 30%, it can be tried. And but with bromocriptine, it has to be given in all the patients. Warfarin and heparin are safe during breastfeeding, but during pregnancy, it's better to give low molecular heparin. NOAC, no clear data available, so it should be avoided. So anticoagulation, prophylactically, no. Therapeutic, yes, definitely when you're getting an intracardiac thrombus, systemic embolism, AF, or patient is on bromocriptine. So what is the class of recommendation according to ESC? It's a class 2A only when you are giving bromocriptine in these patients, along with you have to give anticoagulation. So if we see that in my patient, she still was having an NYC class 3-4, we started with bromocriptine 2.5 mg OD. And if we see the treatment nutshell, this was a mnemonic which was developed by European Heart Journal Board 2017. Bromocriptine, B stands B. O is oral heart failure drugs, A is anticoagulation, R is relaxant, and D is diuretics. So this mnemonic only used in patients who are quite sick in the patients of peripartum cardiomyopathy. Now my patient comes to me, okay, after say 5 days of delivery, can I breastfeed my child? She is on bromocriptine. Now there will be two groups. If she is on bromocriptine or she is not on bromocriptine. If she is on bromocriptine, obviously the breastfeeding will be decreased. It's usually not advisable. But if she is not on bromocriptine, then what should we advise? Earlier there was a concept that when we breastfeed these patients, there will be increased demand and increased sympathetic drive, which may lead to more dysfunction in these cases. So now the recent concept says this has not been shown in any data that breastfeeding causes more harm in these cases. So we have to advise these patients that you have to continue with the breastfeeding. As already told, the drugs which are safe during breastfeeding should be given only these patients. And this data which I'm telling is came from 2019. They compared the two groups with breastfeeding and without breastfeeding of peripartum cardiomyopathy. And they didn't find any difference in your terms of your LV dysfunction or in terms of your recovery or NYHA class. So it is always better whenever the patient is clinically stable with peripartum cardiomyopathy, it should not be discouraged from breastfeeding their infants. They should be asked to continue, especially in low socioeconomic status, when they know that not giving breastfeeding and formula feed can lead to increased infection to the fetus. What about the outcomes? How do they behave? Now my patient is discharged. After 1 month she comes to me. Okay, what is my patient, the husband asked, what is my risk of survival? How I will behave? So outcomes are variable. If we see whatever the data, unfortunately we don't have a very good data from Indian subcontinent, but if we see the different subcontinent, the outcome mortality varies between 2 to 20%. If we see Germany, the outcome is 2%, mortality is 2%, whereas if we see the Africa, the mortality is 20%. So this varies between how the heart failure care is being provided in these cases and what are the different malnutrition risk factors. So depending on this, various risk scores have been devised. They say, okay, risk factors, if the patient is having severe LV dysfunction in terms of less than 30%, of his end diastolic diameter is more than 60, she's having biventricular dysfunction, ECG is having QT interval prolongation, or there is delayed diagnosis or ethnicity, which is a low social status. These all parameters, and the most important is when the time of diagnosis and the presentation. If the delay is very much, then they also behave very poor in these cases. So you have to risk stratify. Since my patient presented quite late after 1 month of symptoms, having a less than ejection 30%, so she will be a high risk case for your developing of your mortality, and outcome will be not very good. Do they recover these peripartum cardiomyopathy? Various studies have shown they recover from 25 to 60%, and it depends on the different ethnicity. Can we predict a score? Recently, 2024 ESC PROM came with a score of your EC PROM, call it a PORM, peripartum cardiomyopathy, and they said if the ejection fraction is more than 35%, if end diastolic diameter is less than 53, if there is a patient belong to a high human development index, that means a developed country, duration of symptom is less than 10 days, QRS is less than 180 milliseconds, and there is preeclampsia, these patients do good. They have a better recovery chances as compared to who don't. So recovery happens, full recovery. After the recovery, should we advise the treatment to be continued? These patients should be continued with the treatment because they have an increase of relapse, and at least for 1 year they should be complete treatment should be given in these cases if despite having a normal LV ejection fraction. Now patient comes after 1 year, her ejection fraction is totally improved. Now what to do? She said, I want to do a second pregnancy. Can I go ahead with it? So that is the biggest challenge which you have to tell to the patient, because the subsequent pregnancy, there is increased risk of development of your peripartum cardiomyopathy. So always do a counseling of contraceptions in these cases. That is always never have an unplanned pregnancy, because you are on the heart failure drugs which can be your teratogenic. And for subsequent pregnancy, relapse is a major concern in these cases. And whether you have to advise them or not, they have various scores which they have been mentioned, that they say if they have a recovery, Despite being recovered, they have a chances of 20% going into a peripartum cardiomyopathy. So if the patient is very much keen on having, you should keep a complete close follow-up and do a stress echo to see the contractile reserve in these cases. So if the patient becomes pregnant, serial monitoring at the first trimester, second trimester, because you don't want to diagnose them late. As late diagnosis will lead to your more chances of poor prognosis in these cases. So summary to my patients, peripartum cardiomyopathy is a rare, as already told, only in females, but it is a potential fatal cardiomyopathy if early diagnosis is not done in these cases. Early diagnosis, multidisciplinary management is essential. Medication which need to be used during pregnancy and postpartum should be aware, and you should be aware of what are the contraindicated drugs. There are still confusion, we really don't know about bromocriptine and anticoagulation should be given in all the cases or not. Lifeline follow-up and pre-conception counseling is a must in these cases, and risk of subsequent pregnancy is still complex. It depends on ejection fraction and requires a shared decision making because we have to save both the mother and the child when they come to us. Thank you.